A good analyst has more impact on healthcare than 99% of doctors. Unpopular opinion alert, maybe. I'm going to start this talk by sharing my story of how I became a data scientist and then later got into healthcare. And I apologize to anybody who has already watched my career day talk on the same subject. But I think, the people who were at Lake City High School that day probably actually not watching this right now. So it all starts when I was a phone sales rep for a place that sold financial research products, but I didn't want to be working for a big company. I actually wanted to be working for a technology startup. And in 2010, I got my wish. So I got recruited. It was a really tough sales pitch. They said, Adam, would you rather sell financial products or would you rather sell brain training to professional sports teams? So what do you think I picked?
Sounds like an easy decision.
It was super easy decision. And for a short time, an unfortunately short time, I was living the dream. So I got to go, my first client was the Pittsburgh Penguins. They had just built a new arena. So I was one of the first people who got to go in their weight room, one of the first people who got to go on the ice, got to see their stacks upon stacks of flat screen TVs that they hadn't installed yet, and one of the first people who got to post up at the smoothie bar. So that was sweet. But I had this nagging question in the back of my mind, which is, how is this company making any money? And unfortunately, that nagging suspicion became all too real when I got a call from the CEO and he told me, Adam, it's been super fun working with you, but we can't afford to pay you because our company is not making any money. So you were one of the last ones in and you will be the first one out. Good luck. And I was not too happy about that. As a matter of fact, I was really bummed. And I called up my friend Lee. You guys aren't supposed to know who that is. Lee was one of the guys who recruited me to the company. And he said, Adam, you have spent the last few months complaining that we've got all this great data, this brain training data on professional athletes, but we're not doing anything with it. Why don't you do something with it? He was right, obviously. I had been complaining about that, and I didn't want to just go get another regular job. I had just left a regular job and was not excited to do that. So I decided to take a chance, and I started working without getting paid. So the program would give us just a real ugly CSV, and I started out, I didn't know how to automate any of the stuff. I just knew it needed to not look like that. I knew it needed to look pretty. So there's this thing you can do in Excel where you can record a macro. And so a macro is just like a list of steps for the program to execute really fast. And if you have two screens, you can record your macro in Excel, and then on the other screen, you can see the Visual Basic code editor, and you can see it populating it with the code that it's going to run the next time you want to run the macro. So for a while, I was just working in Excel and watching it build the code for me. And then I would make some mistakes in there. So I would see a line of code and I would be like, well, I don't actually want it to do that. So I would just delete that line of code and then the program would run better. And then I started to work more in the Visual Basic window and less in the Excel window. I was actually writing the code. And so my macros, I was starting to write functions that would take the data and summarize it, or take the data and format it, or cleanse it. And I was starting to create data visualization. So not just here are the numbers of your brain training session, but here's how they look on a graph. And here's a trend line for you. And here's your team's trend line. And so eventually I was able to stitch this together into a program that would take a raw data file and turn it into a report with a push of one button. And this was over the course of a few weeks. And I knew that I had done something good. And I also knew that my bosses had no idea that I had been doing this work. And I couldn't just be like, oh, hey, I wrote some code. Let's have a job back, please. So I was thinking about it, and I needed to show them, and I couldn't get a meeting with them. I just needed to show them this transformation happening. So I made a hype video, and I have to go back. I will be sad if I have lost this hype video forever. Like, it's not in my Dropbox, but I will try to track it down. But it was just, it was super boring, and the audio was garbage because it was 2011. But it was showing this spreadsheet transforming and becoming a beautiful butterfly full of data visualizations. And so this makes me realize that a good analyst actually has a remarkably similar skill set to a salesperson, because the numbers aren't enough without the communicating and like understanding the needs of the person that you're communicating to. All the data in the world will make no difference. Anyway, so I sent off this hype video, and then that thing that happens like right after you send a text that says I'm sorry. It's like nothing happens, right? And that was what happened to me. I sat in front of my email for like 5 minutes, and then obviously nothing happened. And it was a couple of days later that I got back a really, really positive message, which was, Adam, we are so impressed. We are so proud of you that you were able to accomplish this amazing feat of code. And sorry, buddy, we still don't have any money. But at that point, an interesting thing happened. I had gotten over some sort of hump where I was getting kind of good at this code writing thing, and there were parts of my program I knew that still needed to be improved. So even though I had not gotten the most encouraging news, still wasn't getting paid. I actually just kept working on this thing because I was kind of into it at this point. And that's a clue, by the way, if there are any young people watching. Like, if there's work that you find yourself doing and like excited to do even after the deadline is passed, that might be a clue that this is the type of work that you could consider doubling down on. So obviously the story has a happy ending. A few weeks later, they did hire me back and started paying me again. I spent 5 years at that company, got promoted a couple of times. They sent me all over the world, and I got to work with some really amazing people who, for contractual reasons, I can't disclose the names of, but that was my path to being a data scientist. It was the day I got fired was the day I started becoming a data scientist. But then, just like any job, I got tired of that one after a while, and I started looking for something different. And a friend of a friend told me about this hospital that wanted to hire a person who could do intensive technical reading of the federal government programs and then turn those into a data model. And I was like, how many people in the world could even do this? So I talked to him, and they gave me the job. So with the Affordable Care Act, they started these 3 programs for hospitals: the value-based purchasing program, the hospital-acquired conditions penalty, and the readmissions reduction program. And they all had super complicated formulas for how they were going to be calculated. And this hospital really wanted to be proactive because the programs were putting about 6% of their money at risk, and coincidentally, a decent hospital earns a profit margin of about 6%. So effectively, all of their profit margins were suddenly at risk, at least on their Medicare population. So this hospital really wanted to get in front of that. And so one of my first big wins was I made a model of the hospital-acquired condition program, which 75% of the hospitals in this country get no penalty, and then 25%, they get a huge penalty. So this is a really important one to avoid. And I was able to take the infection data from all across the country and make a nationwide model of here's what nationwide infection rates are going to be, and then here's how our hospital compares. And so that turned into data visualizations like this one, where you can see that it's a 2-year program, and over the course of 2 years, a good hospital will have less than 70 of this C. diff infection. It's not important for you guys to know what C. diff is, other than that if you're in the hospital, you'd be really sad if you get C. diff. You really don't want this infection. And then an average hospital over 2 years would have, of our hospital's size, would have 123 of those. And you could see that only 18 months into this program, we already had 102. So we were on track to be worse than average in this measure. And so if you rolled up all the different kinds of infections that were included in the measure, we made what we called like a risk thermometer. And the risk thermometer showed that if things continue as they are today, if the nation does what we project, and if our hospital does just what it's been doing for the last 18 months, we're going to get a penalty. We're going to get a big penalty. And so because of this, because of the imminent financial risk, and because of the fact that I had done something really cool with the data, they sent me to talk to not just one executive, they sent me to talk to the system senior leadership team. This is less than 1 year into my career as a healthcare data person. I was in front of the system senior leadership team, who are responsible for like $1 billion in revenue. And so this is the crux of my argument that the analyst is more influential than the physician, for the most part. The good analyst has a big impact because they have the ear of senior leadership. They're in the room where the decisions are made. And that was the case here. I recommended that they focus on patient safety indicators, and they may have done that. Unclear how much they focused on patient safety indicators. The point here, though, is that the analyst, especially compared to how long it takes you to get there, this is within 1 year. Imagine a doctor, like they're year one of medical school or maybe year one of residency. They're not getting to have this level of influence. So when you have the ear of senior leadership, sometimes you can reframe the conversation in a more productive way. So Siama, a couple of weeks ago, I mentioned to you that hospital readmissions are profitable, and that creates a perverse incentive for less than optimal care. Irony of all ironies, there's also an idea that is common in healthcare, which is we don't get paid for readmissions. Now, how can both of those things be true? Readmissions are profitable and yet we don't get paid for them? So I think the roots of this misinformation come from a couple of different things.
Can you clarify who we is? Is that the providers or the...
Yes. Hospitals don't get paid for readmissions. So we the people who work, or we the hospital, don't get paid for readmissions. Now, obviously that's ludicrous because we do get paid for readmissions, we the hospital. And so it comes down to a couple of situations. So there's a case where if a patient comes into the hospital with pneumonia and they are discharged from the hospital, but they come back like 2 days later and they still have pneumonia, the insurance company says, no. We're not paying you for 2 hospital stays. We're paying you for 1 hospital stay. So in that case is rare, the hospital indeed did not get paid for the readmission, because they combined the bills, hence the name combo bill. There's one other thing, which I mentioned a second ago, the hospital readmissions reduction program, which does penalize the hospital if your readmissions after certain conditions are worse than the national average. That would be the simple way to explain that program. Still not the same as not getting paid for readmissions. What you do is you get paid for the readmissions, but you get paid a little bit less for every single patient. So, but the most common readmission story is like patient comes in with pneumonia, they get treated for pneumonia, they go home. About a week later, they come back and they have a different condition. Maybe they have sepsis this time and they get treated for sepsis and then they go home again. This is just a very sick person, and the hospital in that case gets paid for both of those hospital stays. No problem. So why is it a problem to have people think that we don't get paid for readmissions? Well, specific to our organization, there was this thing that would happen around budget season. So during budget season, everybody knows there's only so much money to go around, and everybody knows that they kind of have to play the game, right? They have to show how their department is making us more revenue or reducing our costs so that their department can justify a bigger budget. Now, the other thing that some department heads know, quote unquote, know, is that we don't get paid for readmissions. So all the creative plans for requesting more budget seem to revolve around, well, we're going to improve care, which is going to downstream reduce readmissions. And since we don't get paid for readmissions, that's going to save the hospital money. It's flawed reasoning, and we really wanted to fight this misinformation. And so we recruited this physician who knew the business side really well. So this is kind of a rare combination, a doctor who's also really familiar with the insurance rules. And we showed him the numbers, and we got him a super simple story that he could tell to our executive team. And the story was like this. Look, patient care is the most important thing, and when they come back to the hospital, that's not good because it means they're still sick. It means their families are disrupted. We want to keep them out of the hospital because it's the right thing to do. But we have to be clear, every one of those is $10,000 of reimbursement. So if you want to set an aggressive goal for reducing your readmissions, be my guest, but just keep that math in your head. So do you want to reduce readmissions by $500,000? Do you want to reduce readmissions by $1 million? So make a target you can afford to hit was the message he gave the executives. And I'm sure you can imagine the hush that fell over the room when this doctor, a major advocate for quality and safety, he's going right at them about money. So yeah, it really got their attention. And it actually, so this analysis, this use of data, and the only data in this story really is the number that we do get paid for readmissions, and it's $10,000 roughly per readmit. So benefit number one, if managers and directors were trying to submit budgets that included money-saving proposals about readmissions, those got sent back for further revision. But the more interesting thing that happened was the psychological principle of consistency. This is the need to be consistent with what your past self said. So if your past self was like, I am a fitness fanatic, and then you go a week without exercising, then that puts you into a state of cognitive dissonance where you're really disappointed with yourself because your self-image is that of a fitness fanatic. So the executives were faced with a dilemma. Of course, it's natural to say when our organization makes more money, then that's better patient care that we can provide because we can invest in better facilities or more people or whatever. But am I so concerned with our margin that I'm willing to make decisions I know are harmful to patients? Or conversely, will I be consistent with the idea that we prioritize the patient first? And would we make a financially handicapping decision that's consistent with what we keep saying over and over, which is that the patients are at the center? So having this galvanizing idea in the meeting that, hey, don't reduce readmissions too hard or too fast, that forced the executives to be consistent with their past selves and say, no, we can reduce readmissions fast enough. We will find a way to make it work financially. We must do it because it's the right thing for patients. And so that was a big benefit, I thought, to that to that whole situation. So I contend a good analyst can have a big impact because they can move the conversation to a more productive frame.
Just out of curiosity, when you brought in that physician, was that your anticipated response from the audience?
I wish I could say yes, but I can't. We were hoping to start an interesting conversation, but we had no idea where it would go.
It turned out well.
Yeah, no, it turned out honestly better than we could have hoped.
So this, to me, kind of sounds like a lose-lose situation from what you were saying about how, like if you reduce readmission rates, then you'll get less money, which means worse care for patients in the long term, but then you also don't want to sacrifice patients. My question, I guess, is like, this is all nice, right? That the analysts point out these like discrepancies and disparities, but does a good analyst also contribute to a potential like solution to get out of this lose-lose situation?
Great question. So the team and I who put this analysis together, our perspective was that the gravy train would not be running for long, that the government and the other payers were finding more and more creative ways to put us maybe not at risk, but get us closer to fee for value. So knowing that the future would be less and less kind to low quality care, we were always interested in finding a way to tell the story that that higher quality is good for us. So we were never worried about the hospital going out of business because of reducing readmissions too fast. So, and this gets back to the idea that I've shared with you a couple of times, Siamla, that all analysis is persuasion, or all analysis is sales. Right. So, yeah, because we had that operating assumption that we are going to be more at risk tomorrow than we are today, then there's sort of an ends justify the means argument about any story we can tell that will get our senior leaders focused on transforming our healthcare delivery to be better in a value-based or risk-based environment. Any story we can tell them that advances that narrative is a good story. Now, this actually leads perfectly into my last point, which is the dark side of being an analyst or being an influential voice, which is that if you know you have a voice, is it not your responsibility to use your voice responsibly? Boy, I really said that poorly. All right, watch this. When you know you have a voice, you also know you have to use that voice responsibly. So that can be uncomfortable. So instead of sitting in your climate-controlled office writing code, like I personally like to do, that might mean instead you're going to the field and finding out, like, when I see this in the data, what's actually happening to the patient? That way maybe your data model can reflect reality better. Or it might involve, because you're going to be a younger person in the room, you might have to stand up to people who are 20 plus years older than you are and who also make triple your salary and tell them, actually, the data do not support the argument you're making. It's a common situation. It might involve pushing back not just at somebody's conclusions, but at maybe the questions they're asking. Like, why are you asking that? What problem are you trying to solve? This is not a smart thing to have your analyst go research. And then ultimately, I mean, you will find yourself asking a moral question, like, if everybody in my position made the decision I'm making right now of, like, what to share, what not to share, how to frame the story, and share the data. If everyone in my position made the same decision I'm making now, would that make the world a better place? And that's a tough one. And then, of course, if that weren't hard enough, asking yourself the ultimate moral question, then you also have to balance that with maintaining your seat at the table. Now, I know Sheryl Sandberg is not. Sheryl Sandberg and Lean In are not always like the perfection in terms of feminist ideology, but she has a point that I really like, which is, she says, no single fight is worth giving up your seat at the table. So as an analyst, it is appropriate to say, if I'm so much of a buzzkill or so idealistic or so, like, out of sync with the leaders that I'm trying to serve, then they're not going to invite me back. And if you're not invited back, then your influence is gone. So, healthcare data, great job or greatest job? I don't know. But there's great job security because there's just so much work that needs to be done, so much the industry needs to transform, and so much information the industry needs to make that transformation happen. You always have interesting problems to solve, and germane to this presentation, you will have a lot of influence at a young age if you choose to wield it.
I know we kind of talked about it before, but, like, how does addressing personal biases play into being a good analyst?
Totally. Well, so there's a ton of research in persuasion, at least, that you are most persuasive when you admit to your biases up front. If you if it appears that you're giving just a one-sided story of a one-sided story, or like just trying to advance your point, then that's a lot less persuasive to any intelligent audience than saying, hey, look, there are some problems with my argument, but my argument is still X, and here's the evidence I have to support X. And I think a thing smart people and good analysts do is, when there's a counter argument to their story, is that they don't take the weakest version of the counter argument. They don't make a straw man. They actually figure out the strongest version of the counter argument, and they present that. Because if you can present an argument that is stronger than the strongest counter argument, then you have a really persuasive analysis. Okay, shall we adjourn?